Well, I'm going to begin by acknowledging the traditional owners on the lands from which we're all coming from today. I'm on the lands of the Durag and Gundungurra peoples in the Blue Mountains in Katoomba, and I pay my respects to the elders past, present and emerging, and I extend my respects to those Aboriginal and Torres Strait Islander people here present today. And if you want to put in the chat, I'm going to find my chat here so I can watch it all, where you're coming from today, that would be great. And we can think about those different lands together. I think that Isabel has started posting things in the chat. So a little bit of housekeeping before we get started. Obviously, keep your mics muted during Annie's talk. But it'd be really nice if you could turn on your cameras during the discussion and when we have chats with the questions and everything. We are tweeting today, I think. Oh, thank you for everyone putting your lands on there. And Isabel will put the hashtag and our tweet in if you want to follow us. I think that's pretty much it. We all pretty much know what we're doing now, don't we, in this space? We do have Padlet today, or I think we have a number of Padlets today that Annie has developed. So what we're going to try and do is have a really interactive session. So just a little bit of introduction for Annie before we get started. You may or may not know her. She's an early career researcher in speech pathology, and she finished her PhD last year. And so obviously it's her PhD that we're going to hear about today, but we're not just going to hear about the what's and what she found, but we're also going to hear a little bit about the process of doing her PhD, which I think is one of the most interesting elements of the talk today as well. Annie is also the special SIGs, the special interest groups, sorry, something I had a brain freeze. Special interest group coordinator for Warren. That means she kind of oversees brings them together, the different special interest groups that we have, and helps us to synergize them, which is absolutely fantastic. So without further ado, I'm going to pass you over to Annie, who's going to talk about her PhD around improving the effectiveness of teaching support for health science students who are from minority and also from culturally and linguistically diverse backgrounds. Over to you, Annie.
Thank you, Lynn, for that lovely introduction. And I too want to acknowledge my supervisor, who is Professor Alison Purcell, who has recently just moved to Western Sydney University. But she has been a monumental support and mentor and guide. So I couldn't have done this without her. And so it's very important that I acknowledge her. I also want to acknowledge the traditional owners and custodians of the land that I'm personally on, which is the Bidjigal people of the Darug people. It's a clan of the Darug people out in the hills area, which is where I am. And of course, I too acknowledge the land where I usually go on main campus at the of the Gadigal people of the Eora Nation as well, and the knowledge they bring and the care that they take of the land and country that we are on. So I guess, my journey it's about stories, I guess, or I don't tell very good stories. My friends had always laughed at my stories that I don't always end stories well. I sometimes go around the bend, and as someone that as someone that my dad knew a very, very long time ago when he was just learning English and he was trying to learn the word roundabout. It kind of goes round and round and about. And that's kind of a bit of my journey, my story. So instead of me sort of being, I guess, you know, in a sort of very linear way, telling you that story using very traditional words like introduction and, you know, background and, you know, study one, study two. I'm going to tell you my story through some of these often used very common phrases. The first is, I just want to know. And that is the beginning. What did I want to know? And then we will be going through what are we actually looking at here? And I'll be talking about assessment in that section. Is it working? And that part, I'll be talking a little bit about intervention as well. Coming out from that intervention, I have a section called Listen to This, because that was in fact something that we found that we had to pay attention to listening skills. And then the last two bits, you know, which basically was kind of more my PhD journey a little bit. Curiosity killed the cat. As well as then back to the beginning to conclude. So that's how it's going to go. It might not, hopefully it will sort of signpost it a little bit along the way for you. But yes, it is a meandering journey and it did take a long time. And I want to sort of share a little bit with you. And for those of you who may be ECRs or who may be considering research, sometimes it is hard. And but you know, I came out the other end, and I think that that's a story worth telling as well. So I guess my first section is, I just want to know. That was what prompted me to really think about this PhD and the topic. There were many things I wanted to know. I was working as a clinical educator. I coordinated some clinical units at the CDTRC, which is the speech pathology clinic back in Cumberland before we moved to main campus. And there we were encountering a lot of students from a multicultural background, both international students as well as domestic called students. And they were, you know, it was quite a complex situation where they were communicating with each other, obviously communicating with their lecturers, communicating with us as clinical educators, but they were also communicating with their clients, with their patients. And also associated health teams and so on. So I found that this was really quite complex. And for students who, for some students, they were actually not having a great time on clinical placement because of certain challenges, many of them being communication difficulties. But what I actually found was that they brought along with them this really rich cultural knowledge and the ability to actually communicate in their own language. But oftentimes they would tell me, oh, you know, I'm not feeling confident with how I communicate with others. And in fact, you know, sometimes on placement, they did have a difficult time. It was very challenging for some of these students who were not confident with their communication. Or they might have experienced, they were fairly confident until they encountered a situation, and that was a huge challenge for them. So I guess one of my questions that came out from working with these students, amongst the many students that I have, was I did have many questions. I was curious about it. Why do CALD students fail on clinical placement? Why do they have such difficulties? What kind of difficulties do CALD students have that put them at risk of failing their clinical placements? Sometimes, and the literature tells us this, that, you know, students in health professions may not fail. They fail to fail. However, they have such a difficult time, and the clinical educator or their clinical supervisor, university supervisor, would have to help them, give them a lot of support. So yeah, so I guess that's why, you know, I was very curious about that. So if you have the opportunity, you can use the QR code. I think Isabel might have already also put the link in the chat as well. So maybe you can start filling that in because that might start some of our conversations, and I'll be looking back at that later. I guess as we were thinking, as I was thinking about why students might not do well, why they might fail, I actually looked at both some literature as part of my background reading, as well as sort of thinking back what I've observed. And across the literature, they were judged to have poor communication skills. For COLD students particularly, they had errors in pronunciation or accent, differences. They might have difficulties or accuracy problems in grammar and vocabulary, but these are all often commonly seen in ESL speakers. But supervisors also reported that they use words that are not appropriate to that context, or that they had difficulty expressing themselves in grammatically correct sentences. So these are some of the things. And I wonder, you know, afterwards, when I have a look at the Padlet, whether these are some of the things that you might also be putting down. However, you know, my own experience is when we're talking to students, especially speech pathology students, we often do find that their speech was intelligible. I could make out all the words. It's fairly easy to understand, even in the presence of an accent. There were grammatical errors, but it was minor, and it didn't really impact on the general meaning of their message. And some students were very worried about their vocabulary, but for others, they were really quite confident. And often they had that strength in academic writing of vocabulary use. So something was attributing to the impression of poor English proficiency, which is what we often find in the literature. What I observed from the students was that we actually find, or I found, that word choices and phrasing was a little bit different, so often more suitable to presentations, or were more formal in tone than something that we would use in conversation. Perhaps that was one of the difference. They had difficulty conversing or discussing a subject without preparation, or informal or colloquial manner that would normally be expected in a conversation, especially between colleagues or with their supervisor, something slightly more informal. And they had difficulties also with explanations and answering complex questions and understanding those nuances of conversation, responding appropriately. Sometimes they made expressions in errors, errors in expression and phrasing that sounds ungrammatical. Yeah, so I wonder if that's one of the things that, you know, or some of the things that you've been adding to the Padlet. This actually led me to more questions, actually, because I guess, do COLD students who are at risk of failing a placement always have the kinds of problems that people, their clinical educators, the students themselves say that they do? Often they say, oh, it's my accent. I have such a difficult time making myself heard. So that was one of my questions as well. I really wanted to know that. Another thing that I wanted to know also, coming out from that bit of reading and my reflection on what happened, was the strategies that we offered, the strategies that the universities provided, or the clinical coordinator provided to help the students. What are they? What's used out there? Do they work? And how do we know if they worked or not? So as you scan through that Padlet, hopefully you've got a few things to add to that. I'll come back to looking at that Padlet in a minute, if hopefully you have some time to do that right now. Actually, I might just have a look and see how we're going with adjusting. I can see here that there's some ideas of adjusting to the word choice. Yeah. The role, the tone, you know, especially I noticed here about older adults. Yeah, is there an idea that, you know, trying to fit in, trying to feel like they belong. And language plays such a big part of that. Communication might play such a big part of that. Yeah, maybe there are cultural differences. Maybe there are things that they don't know because they've never experienced it, if they are international students, or if they're domestic students but had a lot of interaction with their communities, cultural communities, as opposed to perhaps I guess communities where there are more English as main language users. Yeah, so that's great, fantastic. Thank you for adding to all that, because I think that I do think, you know, perhaps for those of us who may have worked with students, you know, this idea of, oh, do we really know? Do we really think that these are the kind of problems that they say they do have? Or is there something underlying it that then adds to that sense of challenge, difficulty, belonging, the human side of things, I guess. So what did I do? I'm going to leave you to keep writing in that Padlet, but I'll tell you a bit about what I did to find out more, because I was getting more curious. I did a systematic review to look at assessment and intervention between 1990 to December 13. December 2013, and I updated in 2019. And amongst those studies that I included, and of course I started with a huge record of many articles, 11,000, nearly 12,000 or so. We whittled it down to 43 studies, 12 articles on assessment and 31 articles on intervention. And what we were looking for were things that actually helped us understand whether the assessment was effective, whether intervention was effective, whether there was clear reporting on assessments and intervention. And we did that by using some assessments during the systematic review. I used the Best Evidence Medical Education Guide, which is the BEME guide, and I used the Kirkpatrick hierarchy as well, which is adapted from Harvard. And this is a study, this study sort of looks at the impact of any intervention or assessments that might be useful that then can translate into practice. We looked at, the assessment papers, and what we found was that they were really high quality methodology. A lot of them were on simulated patients, on OSCEs, that assessed many different areas of communication: speech, vocabulary, grammar, even things like interaction skills and listening skills, and also note-taking and information gathering. So the assessment papers were really strong, but it didn't really have impact as much. So it had low impact. It had minimal feedback back to the students. There was there was some change to the program, but not often, and change to the institution as well, but again, not often. In terms of intervention, I found that, and we evaluated through the Educational Interventions Critical Appraisal tool with the ICAT, as well as the Cochrane Collaboration Risk of Bias assessment tool. And I found that in terms of assessment papers, unfortunately, they were lower in quality. And because the outcomes were often not measured or reported, it was actually quite difficult to understand, and see the evidence there for the effectiveness of those programs. So that was quite interesting, because I think that we all work really hard with these students. We all want to do really well with these students. And yet when we look at the studies that are actually out there, it's sometimes quite hard to actually know what we did, how we did it, how we measured it, how effective it was. And so what I did coming out of that was really consider how can we better this process? How can we make this a more stronger way of looking at assessment and intervention? And so I proposed a model, a design model for a clinical communication program that integrated both the assessment as well as intervention. because my gut feeling was that, the assessments were so strong, but very little feedback was perhaps given back to the students, which then, and also there wasn't much change in the program. And so perhaps there wasn't that continuity. What was that next step? How did we look after these students who came out from an assessment needing a little bit more help? And then what were we doing within that? So what I wanted to do was look at the full, I guess, progression of what we can do. And so I wanted to have a high impact integrated approach to assessment and intervention design. So it wasn't just one program, but it was actually thinking through how can we design programs? How can we design assessments? Now, oftentimes, when what we do have are assessments within our units. So we might look at course examinations or OSCEs. We might look at clinical competency assessments. We might give some feedback. Then what we might need to do after that is to refer them to an intervention program and maybe do some pre-testing, because that would give us more specific information and develop a test battery that is specific to what the students might need, collect some baselines of program goals so that we're coming up with specific goals for the students. And then in terms of the intervention itself, really looking at intervention, collaborating with specialists there about what is important to work on, looking at dosage, looking at duration, what are the program goals, and how interactive are the practice strategies to during intervention to ensure those goals are reached. Then after that, to actually do some post-testing, to look at outcome measures, to follow up on the data, and to actually evaluate the program themselves. How do we track this? Do we use exam results? Do we use the next clinical placement? Do we look at student satisfaction? That's program evaluation. And then finally, really thinking through about institutional impact. Do we need to look back at the course or the curriculum? Is it within the discipline? Is it faculty-wide? So this was the design model that we proposed at the end of the systematic review. And in 2020, Havery and Johnson actually applied that design model to the first year nursing students. So that was quite pleasing, and they were able to come up with their own program to investigate the communication skills of their nursing students. So that was really quite good. I was pleased to hear about that. But I guess after designing this program, this model, it's time for testing. And I guess that's my next part. Right, what are we going to do now? And the first thing that I was really interested in then, of course, is, well, what happens after the assessment? The students are referred. What is it that they're presenting with? They're referred to maybe a English language program. They're referred to a speech pathology program. Maybe, as speech pathology, while we work ourselves, maybe we are investigating it and sort of assessing them and going, oh, what's going on here? So what are we actually looking at? Do we know clearly? If we think about Impressionist paintings, it's like, oh, I can see clearly what that is. Oh, hang on a minute. Actually, the details are not quite there. It's hard to make out sometimes. Sometimes what we think is one thing might be another thing. So I guess that's what piqued the next part. Just really exploring that next component of really talking about the pre-testing stage now. And that's the next thing that I looked at. So I investigated through assessment the communication profiles of these at-risk CALD students. And so I wanted to really find out what the communication patterns are for these students who had failed a placement or who are at risk and identified by their supervisors. I didn't just stick to speech pathology. I had 11 participants, and we had 7 out of those 11 were speech pathology students. We had non-speech pathology students, 4 of them, and I comprehensively assessed using a range of test battery, test protocols for their speech, language, and pragmatics. This includes some specific pronunciation assessments, intelligibility assessments, scales like acceptability scales. We use published tests as well, like the measure of cognitive linguistic abilities. We use the functional assessment of verbal reasoning and executive strategies, because these are students, and we use a huge amount of language with that. And we looked at discourse and pragmatics as scales. So these are all the things that I looked at. I really wanted to see what's going on here with these students. And from there, I actually found out quite a few things. So I've identified differences between some differences between speech pathology and non-speech pathology students, and that's marked with a little that's marked with, oops, sorry about that, with a little asterisk. In comprehension, there was a difference in story retell, inferential skills, rationale, writing, and these do use more complex language skills, and it's something that, you know, you might be interested in language, you go into speech pathology, it kind of makes sense in many ways. What we actually found was that some things are actually difficult for both. Word stress accuracy, for example, was actually difficult for both. But sometimes we think that speech accuracy, you know, their pronunciation is all about the sounds. But in fact, it wasn't all about the sounds. It was about the stress patterns. It was about intonation of the word and how we actually say the word, which part of it do we emphasize is actually what impacted. We had also low acceptability across both speech and non-speech students. And acceptability is mostly based around prosody. So again, this idea of stress patterns, a bit of rhythm, speed, that sort of thing. Other things that was more difficult for non-speech pathology students were some of these basic language proficiencies. Including vocabulary, but confrontational naming, just, you know, very quickly be able to say the name of that thing, that was hard for both groups. But what was stronger for the speech pathology students was that they were able to actually link words, and if they didn't have that word, they'll try another word, and that was a bit harder for the non-speech pathology students. But high-level language skills, that was hard for all of them. Abstract language, abstract reasoning, for example, they needed a longer response time. Sometimes when reading, they don't always identify the facts accurately. They might have high-level processing, high-level language processing difficulties. And so this was difficult for both groups of students. Now, if we think about the kind of work that we do in clinic, and this was where I was seeing a lot of this difficulty, when we're asking students to explain, now, why are you doing that? What are you doing? Explain and give me the clinical rationale. This is where they have difficulty. So it impacts a lot on their clinical reasoning, but it also, of course, impacts a lot, perhaps, on their discussion with the clients and with the patients. When they're trying to explain this and that and the other, they need that agility in high-level language and in the words that they use to be able to do that. But finally, have a look at pragmatic skills. So pragmatic skills are things like topic maintenance, topic management, things like, you know, even non-verbal things like body language, facial expression, eye contact. And both groups did well in that. But what was difficult was their discourse, their ability to carry out a longer conversation. For some people, it was the ability to actually even start conversation, have small talk, all these things that help with building up that rapport, that facilitation with our client, with our patient, and also with the staff members if we're going to a hospital, if we're going to a community health, to an aged care center for our placement, to a preschool for our placement, to a school. So we can see that, you know, this is where perhaps some of their difficulties have come from. So I looked at standards a little bit, because we are speech pathologists and that's my background. So I kind of thought, well, let's have a look at our competency assessment for our students. And whoa, almost every single part of our competencies. And this, we are up for new standards called professional standards. And but this was mapped to our old one, which we're still using right now. And you can see the kind of professional competencies that the students were needing to reach on their placement. And a lot of them involve communication, either with their supervisors, like reasoning skills, with others, like communication skills, for themselves, lifelong learning skills, professionalism with people like in admin, following instructions, all of that, and then specific clinical competencies, assessments, analysis, writing up reports, writing a session plan that made sense and that had good clinical rationales in it, actually implementing and facilitating therapy. Understanding how to talk to your supervisor, how to engage in that supervisory process, and also to write good reflections. The only thing that they, I guess, didn't have as much impact, I thought, was maybe using the computer system to enter their clients in. Okay, well, as long as they understood the instructions, they should be okay with that. But that's a high number. So I guess my next thing is, then I wonder, for those of you from other disciplines or even within speech pathology, did you find the same thing? How do communication difficulties experienced by your cohort students impact on professional practice and standards? And as clinical educators, isn't that our biggest thing? We want, I think in the heart of every clinical educator is we want our students to succeed. We don't want them to have such a difficult time. What are these difficulties? Or do they do they come in the form of the things that we saw earlier, these things? Did they have low acceptability? Their prosody was a bit off. So maybe it's sort of then impacted on how they were understood. Even though, were their intelligibility high? If we actually think about it. I don't know. I thought that at this point, I might actually open up the floor. And if you want to say anything, you might, want to maybe make a comment on that. It's hard for me to actually see on the chat. So maybe just unmute yourself and say, if you did notice any of these things, or in fact, you found that, certain students actually did in fact have difficulty with basic language proficiency, even though they're in speech pathology. And we can discuss some of the issues that might be part of that, or we can leave the discussion until later. Any thoughts? There's the Padlet as well. So please do add to that Padlet, and I'll be very happy to answer questions on there and continue our discussions by Padlet. And I will, of course, come back to that as well. Let me pop over and have a look at how we're going with that Padlet. Yeah. So that's all right. No questions? That's fine. So I think, I guess one of the things then that I wanted to do after that was to really go deeper and really think about, all right, well, here are things that we do. And I think also, at this point, you might want to go back to that first Padlet, and I'm just going to hop over. It's the very first one that Isabel would have put up, because there's some columns there around strategies. So if you used other strategies, some of the strategies before, if you remember back on this slide, oops, let me just move this slide over. Sorry about that. I'm just going to go back a few slides. If you remember back from this slide, what strategies or programs are there that you've used and whether they've worked or not? So if you're a clinical educator, if you had taught students in any way, maybe you want to put some of those strategies down, and that's from that original first Padlet. So I do encourage you to maybe pop some ideas down, because I guess, you will hear later that there are many things we still don't know. There are many programs we haven't tried. And so we would, I'll definitely be interested in looking at that. Sorry about this scrolling to the next to all the next slide. So just thinking about, is it working? That's my next section. So when I got to looking at the assessment, then of course it made sense for me to think about, all right, what are we doing for intervention in this case? So I explored the intervention design stage, and because they only had a low level of evidence for efficacy of, attending a speech pathology pronunciation program, that was one of the highest ones that they had. They often referred to these programs, to improve their speech. I thought this is the one that I'll try first, because there was just so many programs out there that said that, yes, this is the thing that works. So I thought I'll try it out. So I wanted to develop an effective, high quality evidence-based program. And so I chose to look at improving sound accuracy, because that's what people wanted to work on, their sound accuracy, in improving in actual words, though, not just sounds by themselves, but sound accuracy in words. So the whole pronunciation of the word. And when we're looking at that, then I also wanted to look at improvements in intelligibility and acceptability. The kind of program that I used was an intensive program. And it used the principles of motor learning. And this is a very high dose program where you want to have lots and lots and lots of practice goes at different words. And the words that we use within that are quite complex. So we're often looking at multisyllabic words and looking at longer and harder words. And the point of that is, if they practice those ones, then of course, the easier words would be easier to say. So that's the aim of it. So it was a student-run intensive program at the CDTRC, which is the Speech Pathology Clinic. And at the time it was at Cumberland, we had, the dosage was 3 times a week of individual session of an hour each, and then 1 hour group session. So often they would come in for 3 times a week. So on one of those times, they would have individual as well as a group session. And that ran for 3 weeks. We collected data before that, and we collected data after that. So it was a short, intensive program, and it was designed that way to fit in with them being in between placements, actually. When we were referred, the clinical coordinator said, oh, it's wonderful you're having this program. Excellent, you're doing this research. Can we please have them go in between placement 1 and placement 2? And we went, oh, all right, let's give this a go, because that seems to be logistically what might be helpful for the student. So our outcome measures were looking at word accuracy, and that includes sound, stress patterns, as well as how well they say the words all together. So that's fluency. We looked at acceptability, which is the overall prosody, and we looked at intelligibility, which is basically just sentence by sentence. As they say one sentence, we blindly would write down the sentence to see how many words we got right. And I'll show you the actual results now very quickly. So from our, there were 4 participants, and from our participants of this, we had some really effective learning after the program. Here's the program week. We took some baselines before, then there was the program week, 1 week each, we took a baseline, and then we took baselines after. And you can see that for some of our participants, they did really well after. During the program itself, it was hard work for them. And sometimes we didn't always see a big leap, but in fact, they showed a bit more of a leap and also generalized a little bit afterwards. For some clients, for some participants, they didn't do as well. And so we were curious about that. What's going on there that they didn't do as well? And I'm going to come back to that. The intelligibility and acceptability, you can see also, this is per participant. They were very high in their intelligibility in the first place. So, and given that I did the assessment as well, that did not surprise me that they were quite high on the intelligibility, but their acceptability, if you see there, it was quite low. But post-treatment, for some, it really came up high. So that was interesting in itself. Whereas there wasn't always a huge amount of difference between their intelligibility either way. So what was happening? So despite this being, one of the first really high quality, we really designed it according to everything that we know about pronunciation studies, about speech studies, about motor learning, and high dosage and so on. The results were actually mixed. So most of them did increase their accuracy into the maintenance phase to varying degrees. There wasn't really, sound accuracy changes in sentences though. In intelligibility ratings, as we saw, not that much change, and also only 2 really increase in their acceptability. So that was interesting. And we thought, wait a minute, what is going on? What's an additional factor? And so I actually looked at, then we thought one observation was listening. And in terms of listening, what was happening was that they actually had really great difficulty perceiving the difference between the production of their words versus the production by the clinicians, or some erroneous speech patterns, they just couldn't hear it. So this really impacted on their ability to change their speech pattern. And also the positive gains weren't really transferring to their conversation level. So I did the next thing as also returning then back to the pre-testing stage again, looking at their listening skills about auditory perception. What are the listening skills like of CALD students who were born overseas versus being born in Australia? Did it have an impact on their accuracy, their reaction time, on words or syllables or stress identification? And do they have different speech pathology students? Were they different from other students, other health students? Because we thought, maybe speech pathology students, they're more used to listening to things, maybe they'll be better. So the results for that was that we actually looked at 36 students. And we thought, perhaps in their first and second year of university. And we did some experiments with word identification, reaction time, syllable identification, stress identification. We did a hearing screening, and I did a demographic survey to collect all of that information to see whether we have any results that would come. And we saw that there were decreased accuracy and slower reaction time for word identification for those born overseas compared to those born in Australia. Now, this kind of makes sense because those born in Australia, they're used to the patterns of Australian speech. So they could just click quite quickly. But we found that there were actually no difference in accuracy or reaction time for speech pathology students versus others. It wasn't you get phonetics in your curriculum and therefore you get better at it. No. So physio students, exercise, sports science, I think I had some radiology students who participated, they were no different to the speech pathology students. Also, there were no differences between syllable and stress identification accuracy as well. So they found it equally difficult to identify syllables and stress in words, particularly stress. But there were no statistical difference between native and non-native listeners. So I guess this really made me think, what is it about communication? What influences our communication decisions? We have things in linguistics. We think about content, we think about use, and we think about form. Form are things like grammar, pronunciation, just sort of structures of communication. Content are things like vocabulary, meaning, understanding, information. And use is where we are doing discourse, how we're actually, pragmatic skills, that sort of thing. But around that, we need all of these areas together to be able to use language skills at a high level, to be at that cognitive stage of being able to reason, explain, and so on. And then over that, there's cultural influences. So what I did was then redeveloped something we call Support for Health Interaction Education, SHINE. So this was my revised model. And I'll very quickly just show you some of the differences. So you can see here by my arrows that I've basically specified the kind of things that we can assess and how it and where they can go. So we've changed placement of maybe collaborating with our experts a little bit earlier, really looking at acceptability, listening skills, not just this idea of pronunciation, but really delving into it, looking at high-level skills, really using the Kirkpatrick hierarchy, the ICAT as well, at program evaluation stage, rather than just student satisfaction or tracking results. So these are some of the changes we made, and this is SHINE. This is my new model. And hopefully, with using this model, we can really help the students shine. Now, I guess, curiosity killed the cat. How did I get there? Well, it took forever. It felt like 800 years. Oh, whoops. It felt like 800 years of me getting there. Unfortunately, there was, as I said, it's round and round and bound about. And while I was doing my PhD, along with, all these overly used tropes that I have introduced today that I keep talking about, I'm going to add, this very final one of a long and winding road, constantly being stuck in the mud, lots of pitfalls, lots of potholes. In reality, it was still very long. I was sick a lot of the time, had to take some time off a lot of the time. And even when I wasn't actually needing to go into hospital sometimes, it was just generally quite unwell at home and quite fatigued. So there was work. I had my clinical education work. I had my coordination work. I was an active team member in and with many things. So I had a lot of work to do, and so that was essential though, because I had a mortgage to pay. That's the reality of life. You really, there's no getting away from the reality. Sometimes I just got stuck. And decided that, okay, well, I can't face this anymore. It's all a bit too much. Let's just stick my head in the sand and not look at it for a while. And so, so sometimes, the length of how long it took actually, was me just getting stuck and not being able to move on. I had elderly parents. They don't look terribly elderly. This is where, I don't know, good Asian genes, I guess. So, so I had elderly parents I live with and sort of have to, just sort of manage and look after and so on. And in the course of my PhD, we were looking after three my nephews, 2 nephews and 1 niece. And basically the eldest was born, I think, in the first year of my PhD, in my first year of my candidature. So literally, he's kind of grown up with it. They were over a lot. I was doing a lot of nannying, a lot of babysitting, because it was necessary. And so the pandemic, was kind of a little bit of a relief, actually, especially during complete isolation, because they couldn't come over. It was great for PhD time. But that was, family commitments. And I'm sure that a lot of people might resonate with that, that there's a lot going on. But I couldn't have done this without the support of and the delight of my church and the work that I do with my church and my faith that kept me going, my group of friends who kept me going as well, my excellent friends at work, who, despite us having a lot of work, but we were together and we were doing it together and we were supporting each other. And of course, I couldn't have done it without my supervisor, Alison Purcell, who is my mentor, still is, and she's amazing. And she was guide, coach, sometimes teacher, sometimes, pusher, everything that she could do to get me finished. And so I couldn't have done this without her. But I guess this, this sort of like brings me back to the beginning. of that journey, back to the beginning. I have so many unanswered questions. I wasn't allowed to do everything. One of Alison's thing was, no, you must focus on just one thing. So I wasn't allowed to do everything in terms of intervention and assessment. There's much to go. There's a lot to do. But we now can move forward with thinking and evaluating and researching with clear outcomes and really thinking about impact. We can think about faculty level. We can think about curriculum level. We can think about sort of much higher. I've experienced failure. I've experienced difficulties and hard times. It has really added to my empathy. It had added to my advocacy for our health students from cold backgrounds. And I think, this journey will continue, but I hope that this encourages anyone who's actually struggling out there that you will make it. It will feel like 800 years, and in reality, it is like, it was 8 years. And it took a very long time. But I think coming out of it, it's worth it. And I think then we can really develop more. And so anyone who wants to join me on this journey to continue, I would love it. Thanks, Lynn.
Annie, thank you so much. I really want to say a big thank you. And I don't know if you can put your screens on so we can see you, everyone, but we do have just a couple of minutes now left for questions. But Annie, first of all, I just want to say a massive thank you for sharing your work with us and for sharing your journey, because your journey is really what it's all about as well. And it kind of is what's happening behind the research. And I feel that it's underappreciated, all those struggles and all those, the trials and tribulations really are not what's seen in your PhD, but I think it's super important as part of the story and very, very inspirational. But briefly, do